Good morning. I have no disclosures to make. Callie assigned this topic to me, and I thought to myself, good grief, what is this crazy topic that Callie assigned me? I have no idea what I'm going to do with this. And a friend of mine, while I was thinking that way, said to me, oh my gosh, look at you, what a great topic for you. And I thought, what are you talking about? I don't even know what to do with this. And he said, well, you just took over, an OB division 3 years ago that really hadn't had any attention literally for a decade or more. Like, you're probably an expert on the administrative challenges facing the OB anesthesia provider. And so I thought to myself, okay, what have I dealt with over these past 3 years that you might kind of benefit from my experience? So the first thing is I was in a little bit of an unusual situation. I went down to the University of Chicago, an academic department, very strong academic department, but limited attention and leadership in the OB anesthesia division for a long period of time. So I was in a good division with smart colleagues, but the OB anesthesia practice was somewhat outdated and just not state-of-the-art. And so one of the things that became apparent was that I was going to have to kind of update the quality of care, and discovered that one way to do that was to develop protocols for care. So we'll go through that a little bit, some kind of practical how-tos. The other thing is, I was pretty good on like the ASA guidelines. Like, I read Joy's document. I knew it was in the ASA guidelines. I was pretty good on ACOG as far as like the guidelines that ACOG had that pertained to me. I knew nothing about the Illinois Department of Public Health, nothing. I knew nothing about like JACO regulations. So I'm just going to talk about the most recent JACO perinatal care core measures, and then just spend a couple of minutes at the end talking about drug shortages, because this has just been a thorn in my side. So regarding protocol-driven care, as you know, just a little bit on the rationale, I'm not going to go through this a lot because I think you've heard a lot about it the past few days. This was the Sentinel article, one of the Sentinel articles that came out a few years ago. They introduced a surgical safety checklist in a global population, hospitals at different economic levels. It included what you're all familiar with now, the sign-in, the timeout, and the debriefing at the end. They were able to demonstrate in the pre and post periods that there were decreases in surgical site infection rates, unplanned returns to the operating room, complications, and death. Since that time, all you have to do, you go to a Google Scholar search and plug this in, like 50 different references will pop up. So I think that there are, it's pretty clear that in some circumstances there are outcome improvements when protocol-driven care is utilized. What's interesting, it's not clear exactly why this works. Is it the introduction of the protocol per se, or is it the fact that you have a protocol changes your safety culture? And the answer is it's probably a little bit of both. The same investigators went back to these hospitals that had adopted this checklist, and what they did was they compared the decrease in mortality to compliance with the checklist, and they did show, let's see if this is working today. This is a little bit of a busy slide, but here's like the pre-checklist and post-checklist mortality, which is on the y-axis. Hospitals that had almost 100% compliance with the checklist had the lowest mortality. If you were sometimes compliant, you had, a little bit higher. If you weren't compliant at all, it was, the highest proportion of mortality. Although this may still just represent the fact that if you're compliant with your checklist, you probably have more of a safety culture at your hospital. There's also something to this safety culture thought. Again, same group looked at the hospitals where the checklist had been instituted. This SAQ score just measures staff perceptions and attitudes towards safety. And what they were able to demonstrate was as the SAQ score went up, the effect on complication rate also improved. So it's probably a little bit of both. Can we apply this to our labor and delivery units? Well, the first thing you have to know is, are adverse outcomes preventable, and are they amenable to protocol-driven care? This is Cynthia Berg's data from the state of North Carolina, where they review every maternal death. A panel looks at the cause of death, assesses it for preventability, which is defined as, if something had changed in the care, might we not have ended this way? They then categorize those as related to either preconception care or whether they were related to patient, systems, or quality of care related factors. And they did show that overall 40% of the deaths were considered preventable, and the majority of those were due to either quality of care or systems issues, and like a staggering over 90% of deaths were due to hemorrhage were considered preventable. Same data has been shown for maternal morbidity. This group, this is Stacy Geller's group in Chicago, they looked at episodes of death, near miss, or severe morbidity in their perinatal network. They assessed it for preventability, and they defined it preventability as, was there something that if it had been done or not done differently, would the person have been on a lower point of this continuum from morbidity to mortality? And they found, yes, there was a certain percentage of patients who had morbidity that if something had been done differently, they wouldn't have had that severe morbidity. A percentage, 45% here, who had near-miss morbidity that maybe could have been in this category, and 40% of the deaths maybe could have been in this category. So for instance, preeclampsia is not necessarily preventable, but if a patient didn't get magnesium in a timely fashion and therefore seized, then that was considered preventable. Most of the preventable factors in all three categories were due to provider-related factors. Similar data has been shown in hemorrhage. If you look at hemorrhage with near-miss morbidity or severe morbidity, most of those episodes are considered preventable regarding the severity, and most of the time it's related to provider-related factors. So the good news is that when you have something that's preventable and that's related to provider or systems related factors, then that's the type of thing that sometimes is amenable to protocol driven care. I got in late on Friday, so I didn't hear Kenneth's lecture. I'm sure he went over this SHIELDS data. It's the best evidence to date that introducing a protocol may decrease severity of hemorrhage. They compared pre and post-protocol data. We're able to demonstrate a decrease in severity of hemorrhage, a decrease in the rate of transfusion, and they almost came close to showing a decrease in the rate of development of DIC. So, how to? I get asked this question sometimes from ex-fellows because it's a little bit difficult. In fact, someone was discussing this just yesterday. You're fresh out of your fellowship at an academic institution, or maybe fresh out of your residency, or just some other way taking, you're at a meeting like this, you want to take things back to your practice, and it can be a little bit tricky because you might have people who think, okay, I've been doing this for 20 years, who's this chick from the north side of town trying to tell me how to practice down here on the south side? And so there are some little pearls. First of all, you have to identify your needs. And I was lucky because right around the same time that I started, we had a new medical director on the OB side, and we also got a new nursing director. So all three of us partnered very early. It's important to keep these things multidisciplinary because none of us work in a vacuum. So depending on what you're looking at, you need to get people from your OB service, from anesthesia, from nursing, and then various ancillary services together, for instance, a pharmacy, radiology, etc. Depending on, you know, the circumstances, you might take that person, the naysayer, and put him on a certain policy committee. You know, people all of a sudden aren't so apt to naysay when they have to really sit and defend their views with evidence. And do keep it evidence-based, and there's a lot of help out there. ACOG, the ASA released guidelines, practice guidelines, SOAP releases consensus statements. This is one of our protocols. I just want to point out a couple things. So this was about communication. One of the first things we noticed as far as identifying needs, when I got to the University of Chicago, this is what would happen when there was a crash C-section, and I'm not making this up. I sound like Dave Barry. I'm not making this up. The nurse would come into the boardroom and yell, and then everyone would scatter and yell and try and find each other, or the resident, instead of running in to take care of the patient, would have to stop at a computer, sign in, like Cindy was discussing, wait for the little hourglass, go to the paging system, and then page the anesthesia attending to let him know there was a crash C-section. So of course we thought, okay, we need to create a new way of communicating. This is a table that exists at the end of all of our policies. How many of you have what's called nursing policies on your unit? Probably a lot of you. We no longer have any nursing policies on our unit, or we're attempting to get rid of all of them. We have unit policies. At the end of the policy is a table that summarizes, here's what the nurse is supposed to do, here's what the OB resident's supposed to do, here's what the OB attending is supposed to do, etc. There are no nursing policies, there are unit policies. This is an example of, what is this? We introduced a new oxytocin protocol because, you know, a lot of the data about not running it in wide open and, you know, giving it in a more controlled fashion. So here's what the pharmacy is supposed to do. They are only supposed to make up one type. They have to store it. The OB resident's supposed to put in an order. The RN, or in the operating room, the anesthesiologist is supposed to infuse it in a certain way. Everybody has their job in order for this to work right. You're not going to get buy-in unless you put everyone at the table when you're discussing these protocols. This is our hemorrhage protocol, and again, it's separated by, you know, amount of hemorrhage, but you'll see. Whoops, let's go back. Here's what the nurse is supposed to do, depending on how much blood loss there's been. Here's what the OB is supposed to do. Here's what the anesthesiologist is supposed to do. Now, there's a lot in the literature about the use of cognitive aids, and someone who, Steve Lippman yesterday told you about how when Sullenberger was about to crash, he told his co-pilot, get out the cognitive aid, go through the checklist so that I know what I'm doing and doing it right. And so this can be very useful. He may also have, no, this was, I don't know, someone showed us this yesterday. It was Mark Rollins talking about local anesthetic systemic toxicity. This is available online. We laminated it. It's hooked on to every one of our epidural carts and every one of our anesthesia carts. Because think about this. You're going to see this either 0 or 1 time probably your entire career. You're not going to be good at it. So the use of cognitive aids. We did the same thing. We put this on all the crash carts on labor and delivery and on our ante and postpartum floors. You know, these cognitive aids that are laminated and then just hooked onto the cart. You should try and partner with your electronic medical record providers. This is an example of recently, after I happened to listen with my fellow to Brendan Carvalho's webinar on cesarean analgesia, post-cesarean analgesia, we decided, you know, we could be doing a better job of this. We partnered with our electronic medical record people, and we were able to change things so that, okay, it's probably best practice to be putting people on Tylenol and NSAIDs around the clock for the first couple of days. And so now in our post-C-section orders, this automatically populates. You can uncheck it if there's a contraindication, but you can make it easy for people to do the right thing. This is another example of a way that you can partner with your electronic health record. So now, this is part of our hemorrhage protocol. It's recommended that you do risk stratification. And I mean, you may or may not agree with these categories or these actions, but this is what we decided upon. And yes, I was not able to talk my obstetric providers out of getting a CBC on every single patient who walks in. And maybe there's an important lesson in that too. You have to choose your battles. But anyway, this is ours. Well, first of all, we did create a cognitive aid. So this is laminated and it sits in all our triage bays to remind our nurses about who's at risk and who might need more IV access and when they should maybe call the anesthesia provider about, IV access. But it's also part of the OB residents' admit orders. When the OB resident admits someone, there's a little box where they have to check off various diagnoses, and if one of these diagnoses is checked off, then the blood work and the lab work down in the blood bank automatically populates, okay? It's also recommended that you do a risk stratification shortly before second stage or when you go to the operating room for a C-section. And it just so happens that our OB residents have to do another set of orders when someone proceeds to the OR. So now, when they do those orders, there's a question, does the patient have chorioamnionitis? And if so, it asks, do you want these, do you want to perhaps add another IV or make sure that you've got blood work? And again, this may work in two different ways. Patients with chorio are more likely to have good IV access and have blood set up, but it also may be improving our whole safety culture because now everybody is used to the fact that chorioamnionitis is a risk factor for hemorrhage and a risk factor for transfusion, and I bet even if we took this feature out of the orders, the OB resident would still be ordering it and the nurse would still be asking about it, etc. Similarly, here's our hemorrhage protocol again. We want our nurses, we have certain vital sign triggers. When the nurse charts a vital sign that's outside of this range, she gets what's called a best practice advisory. It pops up on her screen and it says, uh-oh, you've, hit a vital sign trigger. Have you called a physician to the bedside? Similarly, because our protocol, like probably many of your protocols, is based on different levels of actions for different amounts of EBL, as soon as if the nurse charts 300 and then another 100 and then another 150, as soon as she charts that 150, there's a best practice advisory that pops up on her computer screen and says, uh-oh, you've exceeded 500, have you initiated the hemorrhage protocol? The protocol also calls for, doing, I can't quite read that in front of me. Let's see. Oh, doing lab work and repeating it every 60 minutes. At a certain EBL here, this stuff will pre-populate in the orders, and the physician will be asked, do you want to order these labs every 1 hour? It's a reminder. Similarly, at certain levels, we have, you're supposed to set up blood. And, with massive hemorrhage, we enact our massive transfusion protocol. But again, these reminders can flash up on the computer screen. The Joint Commission has suggested that, actually they released a statement called Preventing Maternal Mortality. It was a Sentinel event alert. They suggested that we educate physicians and other clinicians to identify triggers, basically to warn us of hemorrhage and other problems, and that we develop and use protocols and drills for responding to these changes, and that we could use the drills to refine local protocols and identify systems problems. So after you do initiate these protocols on your units, you're supposed to drill on them too. And we had a really good lecture yesterday on drills, so I'm not going to go into that too much. But one thing that I wanted to point out was there's this resource out there called MedEd Portal, and it's online, as you can see, at mededportal.org. And what this is just a resource that talks about drills and simulations. We wanted to do a shoulder dystocia drill on our unit, and we kind of didn't know where to start. And so, again, with our OBs and our neonatologists and our nurses and anesthesia and our people in our simulation center, we went on to MedEd Portal, and it was like, okay, you can just plug in shoulder dystocia, and you'll get all kinds of advice and sample drills for how to do these. So this is a really valuable tool regarding drills if you're starting from scratch and never done anything of that sort. I'd like to tell you about the National Partnership for Maternal Safety. This is a group that was put together by ACOG and ACOG's Council on Patient Safety in Women's Healthcare, together with the CDC, and it's a multidisciplinary organization. There are members from SOAP, there are representatives from the Society of Maternal Fetal Medicine, AWAN sits on the committee, the Joint Commission has gotten involved, and the National Partnership for Maternal Safety is going to be publishing what's called patient safety bundles. The first one's going to be regarding hemorrhage. What these patient safety bundles are going to be are suggestions for protocols and drills. There's going to be samples, suggestions for what a good protocol or what a good drill should include. There's going to be examples of how to review these, do kind of mini RCAs when you have a case of hemorrhage. That's the first one that's going to be released. They're also going to be releasing bundles in the future for like hypertensive disease, for DVT and PE prophylaxis, etc. So this is going to be a valuable resource, and this is going to be released within the next year. So keep your eye out for that. There will be, when it is released, you'll know about it by reading Anesthesia and Analgesia. Speaking of JACO, what exactly is JACO looking at when JACO comes to your perinatal care? Well, they released 5 new core measures, and this is what JACO is going to be looking at on your unit. The first is that they are going to be trying to decrease elective, what they call early term elective deliveries. If it's an elective delivery, it shouldn't be happening till 39 weeks. It shouldn't be happening at 37. The benchmark for this is 0%. They are trying to completely eliminate this practice. They're also trying to decrease the incidence of cesarean deliveries in what they call live-born, nulliparous, term, singleton, vertex parturients. So in other words, normals, okay? And the benchmark for this is 15%. The third one has to do with giving babies a full course of giving mothers a full course of antenatal steroids when indicated. The most common documented reason for not administering steroids will be a woman who just like delivered too quickly and they weren't able to get a whole course on. But the benchmark, when they're able to, is 100%. They're trying to eliminate newborns having septicemia or bacteremia. And then they're also looking at exclusive breast milk feeding. And the benchmark is 75%. Those are the 5 things JACO's looking at. You will notice that there's nothing up there about obstetric anesthesia, okay? And it's very difficult to define quality metrics in obstetric anesthesia. I've been involved in some conversations recently with the ASA, with some leaders of SOAP, regarding quality metrics for obstetric anesthesia, and it's very difficult to do. One of the ones that's been thrown around, for instance, is, well, what about, you know, failure of neuraxial anesthesia? Well, how are you going to define that? Are you going to define that as every time you have to replace a catheter? Beware the law of unintended consequences, because then you're going to have practitioners who leave ill-functioning catheters in place, and that's probably not in anyone's best interest, okay? Are you going to define it as anybody who has a catheter and gets a general anesthetic? Again, that's just going to encourage practitioners to nurse ill-functioning catheters through a C-section. What about wet tap rate? Well, how are you going to gather those data? Who's going to report that if they know it's a sentinel event or a, you know, something that somebody's monitoring? What about headache rate? What somebody suggested, what about blood patch? Again, law of unintended consequences. There's probably a lot of women who need blood patch who aren't going to get it if you call it a quality metric. The things that we could all agree are very serious events, things like, you know, total spinal requiring intubation, okay? That, or like spinal hematoma, neuraxial infection. Those things occur at such a low rate that they're not useful quality metrics. And your very low volume hospitals, if they have even one event, they're going to be way crazy off the scales because it's going to be a very high percentage. The one that's been thrown around most commonly is just overall general anesthesia rate. But nobody knows what the general anesthesia rate should be. Nobody knows the right number. And how do you risk stratify? Because I can tell you something. I moved from the north side of town to the south side of town. I have a very different patient population, and I have a much higher general anesthesia rate. And when I first got there, I thought, oh my God, this is crazy high. I need to look at this. You know what? We have a committee that looks at every general anesthetic in OB. And like almost 100% of the time, we conclude, yeah, I think this was a legitimate general anesthetic. I'm not sure there was anything anybody could have done differently to prevent this. It's a different patient population. They're not as trusting of their medical care providers. They don't necessarily take your advice when they have a BMI of 50 and a class 4 airway and severe preeclampsia. Patients have limited and spotty prenatal care. They don't come into the hospital till they almost have 1 foot in the grave and they crash in triage. It's a very different patient population. How do you risk stratify something like that? So there aren't really any good quality metrics for obstetric anesthesia at this time, and I'm not quite sure what direction this is going to go. I'm just going to spend the last few minutes trying to give you a little bit of advice about drug shortages. All we know is that drug shortages are increasing. This is by year, the number of drug shortages. And they're also increasing in duration. You can see that some of these shortages last for over a year or even 2. This has safety implications because there are treatment delays, or sometimes you have to use drugs that just aren't as good efficacy or side effect-wise. Clinicians are unfamiliar with substitutes. There are many documented cases of like dilution and concentration errors. It's got financial implications, and there are ethical concerns too, because you might have to decide who gets drugs and who doesn't. Makes me glad that I am not an oncologist. Why does this happen? There's multiple reasons, but most of the time it's a manufacturing problem, usually having to do with quality issues that result in either voluntary or involuntary recalls, things like contaminants, bacterial contamination, fungal, impure ingredients, etc. That's what this big blue slice of the pie is. Rarely some raw material shortages. There are economic factors. For instance, when a drug goes off patent and is no longer as financially good to produce it, then there are fewer manufacturers making it out there over time. And anytime you have fewer manufacturers, it's not a good thing, because if one manufacturer shuts down, it has huge implications. They produce with limited excess inventory. They don't want to have to store this stuff because that's costly. The sterile injectables are more susceptible. Again, that's the big piece of the pie here, this kind of yellowish piece of pie, because it's just more complex to manufacture sterile injectables. Again, there are fewer manufacturers, and that's not a good thing. And then anytime there's an increase in demand, we all saw this, you know, I don't know, fentanyl went on shortage. We all said, that's all right, we'll use sufentanil. So, well, the sufentanil manufacturers couldn't meet the demand. What can you do? The FDA is beginning to try and address this, but they cannot force a manufacturer to manufacture a drug, okay? They can require manufacturers to report potential shortages, and they can expedite their reviews and inspections of these places when they suspect that something might have implications. They also have, like with propofol, approved importation of drugs, which is a little bit unusual. They're talking about maybe trying to legislate ways to make generic production of drug more profitable. But that's still out there as a maybe. What can you do? The only advice that I can give you is to work very closely with your pharmacist to find alternatives and change your workflow practices. But it is not easy. There are resources available out there, though. There are resources. There's advice on the FDA website, and also this is the American Society of Healthcare Pharmacists. There's advice on that on those websites. SOAP members can always, you know, go to the SOAP website and ask SOAP a question, because sometimes it's useful just to ask, you know, what are you guys doing? Okay, I ran out of chloroprocaine, what are you guys doing? I ran out of IV nitroglycerin, what are you guys doing? That can be very helpful. And then your pharmacist should be notifying the FDA and the ASHP on those websites. In closing, I just want to invite everyone to the SOAP annual meeting, which is going to be in May in Toronto. I hope to see some of you there. Thank you.